Welcome back to session 2.2, where we're going to explore decision-making surrounding patients who present to the emergency department with an evolving airway obstruction. We have three new panelists in this session. John Sackles, an emergency physician from the University of Arizona. Reza Nurai, an ENT surgeon from the UK, and Adam Rehak, consultant anaesthetist from Sydney, Australia. Thank you very much, everyone, for joining us, and fantastic to have an international panel this afternoon. We're going to, in this session, we're going to explore the tools that are at the disposal of the airway team in order to assess a patient's airway in the emergency department. And we're going to consider which patient factors are going to contribute to the decision about the urgency in which that airway should be managed, as well as the importance of having a plan in the case of deterioration. So we're going to continue to follow our patient with a traumatic airway injury. And just as a reminder, this patient has been picked up from a remote location and he's been transferred via road without his airway being secured. He's about to arrive in the ED. As an anaesthetist, I'm going to exercise my right to be biased, and I'm going to give the anaesthetist on the panel the opportunity to speak first. And I recognise this might be a bit controversial since we're discussing management in the emergency department, and we're incredibly fortunate to have a guru in emergency medicine on this panel. And I assure you, John, we are going to lean on your knowledge and vast experience very soon. For those of you that haven't read Adam Rehak's 2019 article, Managing Airway Trauma, Applying Logic and Structure to the Anaesthetic Decision-Making Process, I commend this to everyone. It's an excellent article, and it discusses a decision matrix that takes into account sort of patient, situational and team factors. Adam, I wonder if you could please give us a brief overview of your approach to airway triage.
Okay, so the reason I came to the conclusion that we needed to have an approach to airway triage was a recognition that clinicians from all specialties were focusing on these threatened airway situations with a fixation on one size fits all, that there should be one airway technique for these particular pathologies. Again, like the first session, they weren't looking at non-patient factors. I think that the critical non-patient factors that are going to have a major impact on your ability, what you are able to do with these patients, is the urgency of the situation, and the correlate of that is where the airway is going to have to be managed, and the other side of that is the compliance of the patient. And so taking those factors into account, we then are able to more accurately and objectively decide what is possible and who's around and what equipment's available. So I try to divide the patients into the crack-on category, which are really the patients that are on such a trajectory that you don't have time to get fancy. You really have to, like our previous speakers talked about, get on, do a rapid sequence induction well, have a backup plan for that, but just recognise that that is acceptable in this set of circumstances. Then you've got the patients that are a little bit more stable and you've got time to think about some more complex modes of airway management, but you've got time to bring people to you and get the environment how you want it, but maybe a little bit too unstable to move the patient to the operating theatre. And I'd add the proviso here that this triage category is sort of predicated on the type of system that we work in Australia and New Zealand, where most emergency departments aren't stocked with the kind of equipment that we might need for many complex airway interventions. And then you've got the third category, which is the head for home, which again, it's anaesthetic focused, where we can head to the operating theatre, probably via the CT scanner on the way, and we're fully armed with more knowledge about the airway and whatever a technique might be available in the operating theatre.
Thanks, Adam. I love the simplicity. Crack on, stay and play, head for home. All right, so look, our focus at the moment is to work out the urgency as to how quickly do we need to manage this patient's airway. Reza, I'm going to direct this question to you. As an ENT surgeon, how do you assess the airway in this patient who arrives to the emergency department?
Thank you very much. I look at airways in three different ways. With clinical information we have about the patient, and a good deal of that is the information we have before the patient arrives to the emergency department. On the main, by the time I get called as an ENT surgeon, there is concern on the part of the anesthetist and the emergency clinician that we may need a surgical airway. So I see a proportion of airway patients, not necessarily every one of them immediately. So clinical would be, how stable is the patient, what's the respiratory rate, use of accessory muscles, whether the voice is muffled, whether there is a stridor, whether there is evidence of surgical emphysema. If they walk in, as it were, compatible with life or brought in compatible with life, you want to try and predict that trajectory. And a lot of that comes from basic clinical information and observations, mechanism of injury, energy imparted in the case of a blunt trauma or penetrating trauma. You want to predict how quickly they are likely to swell and become unstable or bleed. The next bit of information, which is absolutely critical, is flexible nasoendoscopy. And what you are trying to do is to identify any obstructions, distortions, or fragility of the path to intubation. So you want to assess the nose for awake nasotracheal intubations. You want to see the oropharynx and hypopharynx, how distorted it looks. And there are techniques you can use to peek into the subglottis and trachea in a simple unanesthetized patient in the emergency department. And the next bit of information, as been alluded to, is radiological. With airway trauma and airway emergency, every item of information you have gives you benefit in terms of predicting the plan, but it also comes at a cost of, can you transfer a patient to a CT scan decision? So clinical, radiological, and endoscopic.
Thanks, Reza. And with particularly with those investigations, coming back to that patient that we've described with the blunt neck trauma, what sort of pathology are you considering? What are we looking for, or what are we looking to exclude?
So within the oral cavity oropharynx, given the mechanism of injury, you may have some swelling that could affect your path to intubation. The primary pathology you worry about is crush injury of the larynx, and with that, swelling of the epiglottis, swelling and distortion of the laryngeal inlet. And the one that is easy to miss but potentially can affect things and deceptively asymptomatic at earlier stages is laryngotracheal separation. And bleeding into the airway. And most of those you ought to be able to rapidly triage with a videolaryngoscopy in conjunction with your anesthetic and emergency physician colleagues.
That's painted a pretty potentially scary picture for us, Reza. Thanks for that. So I'd like to bring us back to our patient now. And this patient's just hit triage. He still has stridor, and now he's reluctant to lie flat. He's mildly dyspneic. He's struggling to complete full sentences. He's agitated, but still compliant. We have an oxygen saturation of 92% on a non-rebreathing mask at 15 litres per minute. We have a respiratory rate of 28, a heart rate of 100, and a stable blood pressure of 150. He's had a lateral neck X-ray that shows, concerningly, some subcutaneous emphysema. And he's had a nasendoscopy. And Reza, perhaps you could just take us through what we are seeing on this nasendoscopy is concerning.
Right. So you're seeing some swelling and bruising of the arytenoid cartilage. I can just at the end see that the vocal cords are abducting. Doesn't appear complete. No sound, so we can't assess a stridor. and you cannot see the laryngotracheal junction below. But there is bruising and swelling, and with that, there is the concern that this swelling will progress further and lead to immediate supraglottic level airway obstruction acutely.
Fantastic. Thanks. Thanks very much, Reza. All right. So, John, let's assume that this patient's in your emergency department, and it's time that we all benefit from your experience with managing patients just like this. If you haven't yet had the opportunity to watch it, I commend John's presentation to you all on he calls it the 10 tricks, but I think it's about 15 tricks for awake tracheal intubation in the emergency department. And in the next session, we're going to discuss a bit more about those techniques and equipment. But John, what I want to talk about now is, how do you decide which patients need immediate intervention and which patients can wait?
Well, we have the benefit of the situation of a relatively long pre-hospital transport, and based on what we're hearing, it appears that he's deteriorated during that transport. So it's probably been 60 minutes now, and the stridor is worse, the hypoxemia is worse. So I think there's definitely an urgency involved here, because if this progresses, you could wind up with complete airway obstruction and then a can't intubate, can't oxygenate situation. So I think in this circumstance, it mandates fairly urgent airway control.
Okay. Coming back to sort of the crack on, stay and play, head for home type airway triage that Adam introduced us to just a moment ago, would it be fair to say that there is some time in which to secure this patient's airway? You don't need to do it immediately?
Here, this is an airway that I think you probably have 15 to 30 minutes to get the airway secured. I would use that as a time frame. He doesn't need to be RSI'd right when he rolls in the door. I think based on what we're seeing, we have some time. So I would plan on approach to airway management that would get the airway secured in about a 30-minute time frame.
That's great that you've been able to sort of put that sort of time frame on, because that really helps us. I guess then it's less about where we're going to manage the airway, but more about, how long have we got, and that where could really be different depending on which institution you're working in. All right, I'm going to throw another what if at our panel members, like we did in the last session. So if we have this patient that we've just described, that we thought we had enough time, perhaps we had that 15 to 30 minutes in which to gather resources or to execute whatever complex airway technique you'd ideally use, but then in front of you, the patient deteriorates and needs immediate airway management. John, I'll start with you. What would your approach be?
I think this is one of the few patients that I think the safest option would be to go onto an immediate surgical airway. I think doing anything from above in a high-risk situation like this is fairly risky, and probably the safest option would be an awake tracheostomy in the emergency department.
I'll ask the surgeon on the panel. Does the surgeon on the panel agree with that as your crack-on plan?
I would absolutely, and the reason I would is because is, as John says, but also, looking at the nasoendoscopy at that point, it is something that one ought to be able to go from above. That swelling wouldn't necessarily deteriorate within a minute or two in front of you. So the fact that that patient has deteriorated that quickly makes me concerned about laryngotracheal separation with the mechanism of injury. And we don't know that from the endoscopy, whether it is or it is not present. So going from the above runs the risk of creating a false passage into the neck. And I would be more concerned about that, given that we know there is surgical emphysema. I would consider this patient under the difficult Airway Society airway management situation with an impalpable membrane. So I would make a long incision, and I would secure a surgical airway, whether it's cricothyroidotomy, whether it is a tracheostomy. Whether you find something that is ruptured, you go through it. By whatever means we secure that airway, it can be fixed later. But I absolutely would agree, it's a rare situation. You go primarily for a surgical airway in emergency department once the patient deteriorates in front of you.
And just so I understand, that is primarily because of a concern about the potential for laryngotracheal separation.
You don't see anything on that nasoendoscopy that easily explains the surgical emphysema and very rapid deterioration of the patient. Given the mechanism of injury, an injury below where you can observe is a very real possibility. And going from the above, effectively, as John implies, you are going in blind. And you may also have had further swelling in the meantime that makes your exposure more difficult. So for those two reasons, but primarily because I can't explain surgical emphysema in that situation, I'm concerned about anything below the larynx with that mechanism of injury. You want to expose the area, find a place you could find the airway and go into it, think about what you do next later. Anything you do in that situation can be repaired, other than death or brain injury. So you want that airway.
Yeah, that makes complete sense. And, as John sort of mentioned, if we do have a little bit of time, it certainly sounds like there is benefit in being able to use some of the complex airway techniques that we're going to go on and talk about a little bit more in the next session. I just want to take a very brief sidestep from this patient that we're discussing, not just because it's a terrifying situation, but because I want to pick up on something that John discussed in his rapid sequence presentation. That was it was something fairly unique that I haven't really heard of discussed in the context that John mentioned, and that is the physiologically difficult airway. John, I found that really interesting, and I was just wondering if you could elaborate on your comments about the physiologically difficult airway. What is that? For the audience members like me that may not have heard of that before, what is it, and what is the impact of the physiologically difficult airway on your airway plan?
Well, we wrote a paper described the physiologically difficult airway a few years back. And how we define it is a patient that's at great risk of cardiovascular collapse due to hypoxemia or hypotension during intubation. And RSI is a wonderful way to intubate patients. It gives you excellent intubation conditions. You have a higher first pass success, less complications. So in the vast majority of ED patients, it's a reasonable thing to do. Now, in the anatomically difficult airway, the risks are appreciated and those patients undergo awake intubation. And I guess the point that I'd like to raise is there are patients with physiologically difficult airways that despite resuscitation with oxygenation and fluids and pressures and bloods regardless, that they're still not optimized to undergo RSI, and you have refractory hypoxemia or refractory hypotension. And I think RSI is a dangerous approach in those patients. One, because when you push the drugs, you have a period of apnea, and some of these patients have apnea intolerance in that their sats are less than 90% when you're starting, so they're going to desaturate very rapidly. And other patients that are hemodynamically compromised, for example, the patient with acute right heart failure, really can't tolerate the push of a large induction agent and may cause cardiovascular collapse. So I think in a small subset of these patients with extreme physiologic derangements, awake tracheal intubation makes sense, just as you would do it with a patient with an anatomically difficult airway. Doing the awake intubation in the emergency department allows you to preserve spontaneous ventilation so they don't desaturate during intubation. And obviously you maintain oxygenation while you're doing the intubation. So typically I would use Vapotherm or OptiFlow and oxygenate them throughout the procedure, but they're breathing spontaneously. And then it avoids the large push of sedative anesthetic agents that can cause some hemodynamic compromise. So you avoid the complications of apnea and hypotension associated with RSI in this group of patients.
Yeah, look, that's fascinating, John, and I'm really looking forward to in the next session hearing more about the complex airway techniques that you can use in the emergency department and exploring those in more detail. Nick, is there any questions coming through from the audience for our panel members?
Thanks, Lois. I'll just also mention there's a couple of great papers by John on the physiologically difficult airway. We put the links up to them on the website. Question for the panel. Would you be able to talk about how oxygenation could be safely maintained during an awake tracheostomy in a mildly hypoxemic patient, I suppose also in the context of a potential airway disruption? And maybe just come to me, Reza, is there a contraindication to high flow nasal oxygen in these sorts of patients?
Thanks, Nick. It's a balancing act in the case. In the particular patient discussed, I don't think so, and there are benefits from it, which we can go to. If you have a craniomaxillofacial trauma and you have worries about base of a skull fracture and pneumocephalus, then you would consider nasal high flow with caution. But in this particular patient, it would be very beneficial on a number of levels to try it.
Fantastic. Back to you,
Just
Louise.
to add to that, sorry, it's interesting, and I'm sure there aren't enough published cases to really know the answer to this, but we'll talk about a paper by Mercer and Groom and colleagues from the Aintree in the next session. But they sort of published their algorithm and systematic review on management of airway trauma. And in their initial paper, they advocated high flow nasal oxygen, and I have noted they've added an addendum to that paper to say that they would only use nasal oxygen at 15 litres per minute, and have gone back on that. But speaking to Peter Groom about this, it's not based on any evidence. It's their sense that they don't want to advocate something that hasn't been proven safe in a disrupted airway, but they haven't actually seen it cause worsening of any subcutaneous emphysema.
Thanks, Adam, and thanks, Reza. It was something that I'd wondered about, the use of high flow oxygen in a traumatic injured airway, and something that we'll pick up again in the next session. For now, I'd like to thank our panel members for a fabulous start to the discussion about managing this patient in the emergency department. Adam Rehak will be leaving us now. Thanks, Adam, for joining us and for sharing that fabulous scaffold to help think about airway triage. We're going to hear more from John and from Reza when we continue to discuss this patient in the next session. So far we've talked about the tools that might be useful to the airway team to assess a patient's airway in the emergency department, and Reza particularly, in addition to the clinical assessment, talked about nasal endoscopy and, if it's safe to do so, radiological imaging like CT. We discussed a little bit about how we assess how urgently a patient's airway needs to be managed, and in turn that might dictate where you need to manage that airway. And we discussed the importance of having a plan in case of an unexpected or sudden deterioration, and for the panel members that we heard from, that was sounding like it was going to be a surgical airway in this instance. We're going to take a quick break and we'll be back with you very soon.